So a lot of new stuff at the 2017 Genitourinary Cancer Symposium in Orlando. A lot of new stuff in renal cell carcinoma. We do have data from a trial combining a PD-L1 inhibitor atezolizumab plus bevacizumab versus sunitinib versus single agent atezolizumab. And the trial did not meet its primary endpoint of progression-free survival. However, there was a very interesting trend in a superior progression-free survival in patients that were biomarker chosen as PD-L1 positive in this trial. Trial sponsored by Roche Genentech, presented by Dr. McDermott and Powells. Another abstract is dealing specifically with the case of circulating free DNA, which is an emerging liquid biopsies, as we all know. Data from Guardant presented by Dr. Monty Pal in the oral session, showing that 80% of the time you can detect circulating free DNA. And the interesting thing about that study is that percentage and mutations, the percentage of mutations, a change across lines of therapy, possibly due to pressure selection. So this is also a very interesting publication from Dr. Pal's group. There was also a presentation specifically tailored at a rare subtype of renal cell cancer, which is papillary renal cell cancer, that involves savolitinib, which is specific MET inhibitor, an oral MET inhibitor. And interesting enough, while the overall response rate were low in the whole population with metastatic papillary renal cell cancer, when we look at those patients that are MET-driven, whether by a mutation, by chromosome 7 duplication, or amplification, only responders were in that subgroup up to 18%, and the progression-free survival was certainly higher. So that justifies using this drug in a biomarker driven study of papillary RCC. There was also some early stage abstract dealing with surveillance in T1 stage 1 renal cell cancer, including also there was abstract dealing with actually surveillance, but in metastatic renal cell cancer. And again, it's what we already know in part, which is patient with good prognostic risk factors in metastatic RCC, patient with limited disease burden. We can wait up to 1 year sometimes to start systemic therapy. So it's a rich meeting. A lot of good work, both from the lab as well as clinical work presented in the kidney session, which is on Saturday at the GU Cancer Symposium. Thank you.